it looks like almost like barbed wire. And this is like a hand file, but with like these sort of catches on them. I feel like this pulp tissue is being removed ever so slightly. Maybe it's getting stuck in the apical third here. When we look very closely, we irrigate and aspirate the MB canal. And what we notice straight away is that the MB2 also drains at the same time. So, hello, welcome to this week's Friday clinical case. And today I'm going to use an almost barbaric dental instrument, which I hardly ever use. And I think I didn't actually have this on in my surgery. I had to ask another clinician for this, and this is using barbed broaches to remove um, intact pulps. So it's a bit of a gory episode today, but all fun. But before we get into the whole case and I present the case, what I want to say is we've got a brand new 30,000 subscriber giveaway. We're so tantalizing close to 30,000 subscribers on the channel, and this is the brand new Root ZX Apex locator. So the Root ZX Apex locator has been out for many years, and this is the Root ZX3. So if you want the chance to win this, you've got to do three things. The first thing is, of course, you've got to subscribe. It's a subscriber giveaway. But also, if you hit that subscribe button, it gets us quicker to that point. The second thing I want you to do is I want you to comment in the section below this video a question. It can be any question. It can be what the hardest thing you find in endodontics, or whatever question you want to ask me, endodontic related, of course. Ask that. And the third thing you need to do is hit the notification button. If you hit the notification button, it notifies you for all the brand new videos that are uploaded, and also it notifies you on how to when this giveaway is going to be carried out. We've also got a membership program. The membership program is run by YouTube. It's a small monthly fee. You get early access to content, and you also get exclusive content. So let's get on with the case. So this is a case of an upper left 6. And this was an external referral. So this patient was referred to me outside of the practice, and they'd had some kind of toothache, maybe on holiday or they were away, and the tooth was dressed. And they went back to the normal dentist, and they took one look at this periapical radiograph, thought a bit difficult, and it was sent to me. And when we assessed this periapical radiograph, we can see that the pulp chamber is massive, very open, and also we've got these kind of weird spindly roots. So this when I look at this tooth, I think regardless, the pulp chambers are open. So I can't remember the patient's age in this, but you can indicate by how big these pulp chambers are. It's that this patient's probably in their early to sort of early to late 20s, and but we look at the roots themselves; they're not absolutely obvious on the periapical radiograph. So the chance to muck things up here are really easy, and I suppose when we opened up the tooth, we noticed this tooth's got quite a vital pulp, and we're going to get into the management of that. But the problem with vital pulps is this. This is from an earlier video, maybe last week. Is that we actually removed some pulp, and then we let it dry out a little bit, and then what I noticed is this dried sort of pulp connective tissue is quite gluey, quite kind of tacky, and what you've got to be super careful is you don't compact this pulp tissue down into the canal, because as well as dentin chips or debris or like little bits of filling material can get trapped and block the canal orifices. If you compact the connective tissue of the pulp chamber down the canal orifices, it will temporarily block it. And essentially what you'll have to wait for is you dress the tooth. This is, of course, if you block the tooth with the pulp tissue itself, and just let it either necrose or dissolve via, intracanal medicaments or with a bleach. So we move over to the video, and obviously the first thing we need to do is place rubber dam. In this case, I'm just checking a couple of little clamps to see if they fit. Obviously, I'm going to flip over the rubber dam sheets over the clamp, give it a little bit of wiggle so the dam fits around the tooth really, really nicely. And then sometimes the rubber dam doesn't fit over the face perfectly. Sometimes it covers the nose. So what you'll notice me here doing is I readjust the rubber dam sheet, so I kind of fold up the bit that sits up here and I move the frame downwards. And then when we look at the tooth really, really close up, I notice that I've got a massive screen on the wall over there. It isn't clear compared to what I can see in my eyepieces. So what I am doing here is I'm parfocaling the microscope. So I'm making sure that the microscope has got automatic focus on it. So I'm going to automatically focus the microscope so it looks clear on the television. And then once I know that the microscope itself is clear, if I'm still seeing it's not focused in my eyepieces, the eyepieces that need to be adjusted. So I just close one eye, adjust the eyepiece on one eye, close the other eye, adjust it, and then everything is completely in focus, because it's not really a major issue if you're not recording your cases, or there's a massive screen on the wall. But what you'd prefer is what you see in your eyes is clear, and also what you can see on the microscope is clear as well. Because I suppose in a way, if you're not recording your cases all the time, sometimes you want to take a couple of pickies, and sometimes it's difficult if you're looking down your eyepiece and it's blurry or it's sharp, and then when you want to take a quick picture and the image is blurry. So we're ready to cut the access cavity here. This tooth has already been accessed by a referring dentist, so it's just a case of undermining the GIC and just sort of having a little look. And straight away we can see here that the canal, the pulp chamber, is full of vital tissue. Now, I did mention before is that, there's a possible argument here to say that maybe this should have been a partial pulpotomy. I think my opinion with these things is that I not have great cases where these have worked. I've not had great success with these types of cases, so I feel like this is such a huge exposure. I also don't really know where what's been dressed on this tooth. So I think in the best case scenario here is just to remove the pulp chamber completely. We'll probably have quite a few endodontists here who would say this is the wrong approach, but in my case, I think it's the best approach. So I'm just using an ultrasonic here just to remove some of the pulp chamber, just see if it comes away. And I want to remove this pulp tissue all in one. And I feel like the best canal to go down first is the plate, because that's usually the biggest piece of pulp tissue you can remove. I'm using a H file here just to try and hook some of the palatal tissue out. But what I notice is the pulp tissue here is quite adhered to the sort of canal wall. So I'm just using a hooked instrument here, just to sort of try and hook this pulp chamber out. I also think this pulp tissue, not pulp chamber, is also stuck onto a little bit of pulp tissue further down the canal. So it is a little bit loose, but I think that it is stuck. So I'm trying to remove it all, but I feel like I'll probably remove, maybe it'll probably tear at some point. So I'm just gently teasing this out, and introduce these absolutely barbaric barbed broaches here. So if we sort of do like a bit of a close up, we can see that these like little barbs, it looks like almost like barbed wire. And this is like a hand file, but with like these sort of catches on them. And we're going to try and use this instrument to negotiate down into the canal to hook or barb onto the pulp tissue and then hook it out. And this is, I think this is one of the larger barb brooches that we've got here, because I feel like the pulp chamber in the canal orifice and the diameter in the palatal is quite wide. We have a little bit of a screw in. Of course, I don't want to sort of shear off the pulp chamber. Want to pull it all in one. You know, we have a little feel around, we have a little bit of a clean out, we have a little feel, and then I'm back onto this hooked instrument because I feel like the barb brooches aren't working very well, and I feel like, you know, this pulp tissue is being removed ever so slightly. Maybe, you know, it's getting stuck in the apical third here. But this little hooked instrument, I feel like it's working a bit better than a barb brooch. But, you know, it's at this point we feel like a little bit of a tug, and then we pull out, I would say, possibly 75% of the pulp chamber. And when we have a really, really close look here, we can see that this is the pulp tissue, and this is probably, bar, you know, a central incisor, the largest bit of pulp tissue that you're going to probably ever see ever. But you know, I feel like that isn't long enough for the whole palatal, and I think, you know, is it worth my time trying to remove the pulp tissue from the MB and the DB? And it might be better use of our time really just to dissolve this in hypochlorite. You know, we'd like to take as much time as we like with patients, of course, we do. And, you know, I try with a couple of barb brooches to try and hook the pieces out. But I think what's probably in the patient's best interest, and I'm just going to let the bleach work its magic. I'm going to let the bleach kind of dissolve the tissue. Of course, there's always that risk that, you know, if it is partially vital, that it's going to block the canal orifices. But, you know, with this in mind, it's always important, obviously, just to make sure you've got a glide path, and you're not using kind of a push and pull motion when you are, you know, you're shaping this tooth. So we're ready to take a working length X-ray, but this screams 0 straight away, and I sort of pull the. This is in the palatal canal, of course. I pull the file out, and I just feel like the file's too far out for this to be a reliable reading, and what I suspect is that the canal is just filled up with too much liquid. So I just get my I just aspirate some of the liquid out. I remove the liquid, the vast majority, from the cavity, and then but I keep a little bit in the canal orifice itself, and now we can see there's much more accurate reading. But at this point we're not quite reaching past that 0 mark. So I get my hand file, I make a very small bend at the end, and then I have a little feel around, we push it to length, and now this pushes through the apex. And of course, if you watch a lot of my videos, you'll notice that I like to push the hand file through the apex just a tiny little bit. You don't want to ram it too much, and then I back up the hand file, and then that is our correct working length. Of course, it's always a little bit tricky, isn't it, to kind of keep the hand file in place and then move the stopper up and down. And of course, when you move the stopper, this might sort of inadvertently push the file inwards. So it's kind of that fine balance between moving the stopper, making sure you're at the correct 0 reading, moving the stopper, and then making sure, of course, you're at the correct length. And when we pull this hand file out and we measure it, we can see that the measurement is 19 millimeters. And shaping the palatal is pretty straightforward. You know, I'm going to go straight for a size 15 glide path file to length, and then I use a size 25 finishing file. We're then ready to shape the distobuccal. Again, same kind of protocol. I'm just going to push my D-finder, and you know, a little bit of watch winding, and this goes to length pretty nicely. At this point, I'm on top of the world because I know I've got the palatal shaped. I've got 0 already with the DB. Again, it's the same kind of protocol with the working length. Push it out the end. You know, move the stopper. Make sure we've still got 0. You can see that maybe there's like a little bit of a red mark here, so we know we're through. We've got to pull it out. So it's a little bit of a fine balancing act. And when we pull the DB out, we get our working length, and again, it's the same shaping protocol. We use a size 15 glide path file and a final shaping with a DB. We're then ready to negotiate the mesiobuccal. Again, we hook it up, and this time it does go straight to 0. And when we have a little feel around with our ham file, we can see that it's just not reaching that 0 point. So I adjust the stopper to find out the furthest point reached. We can see that the furthest point reached is 20.5 millimeters. So I'm going to set my glide path file to 20 millimeters. So I don't want to push it to the actual 0 point where we've reached, because I just want to open up the coronal to mid or even apical third here. And then we're going to get our size 25 finishing file. And then as I'm about to push this in, I'm about to introduce this file to the canal. I just want to just check the end, because just out the corner of my eye, maybe I thought that the flutes have unwound, but they haven't. Really, really important to check that the flutes have unwound, because obviously that's an indication that the tooth is about the file's about to fracture. We clean it all out. The point reached is 20.5 millimeters. So what I'm going to do is I'm going to get a size 8 D finder, and I'm going to set it at 22 millimeters. So this gives me like a few millimeters to see that if I am negotiating, this stopper is going to move towards it, but this stopper is feeling that stop at that same measurement. So again, we do that same old trick. We get a size 8 D finder. We make a little bend at the end, and I feel like I have gone a little bit further, but the apex locator is still showing we're not quite past the level yet, although we give it a little tiny bit of a push, and then we can see that now we've pushed out of the end of the MB canal, which is fantastic. And again, it's the same sort of protocol. We're going to back it out, we're going to adjust the stopper, and then we find out the measurement of the MB was 21 millimeters. So it was about 0.5 millimeters away from the furthest point reach, which is always interesting, isn't it? You feel like you're a million miles away, but it's just that kind of 0.5 millimeters from the zero reading. And again, we're just going to set our glide path file to 21 millimeters. We're going to obviously shape that to 0. We're going to recapitulate, because we know it was finding it difficult to get to working length. And then in this case, I'm not going to go straight up with a size 25 high flex file. I'm gonna do a kind of a phased approach with first a size 20 and then a size 25, because I just feel like going from a size 15 to a 25 just risks ledging, file fracture. I just want a more considered graded up approach to filing this. And when we look at the pulp chamber, we can see that it's really, really nice and clean. There's no pulp tissue at all, and then the canal, the MB2 canal orifice is really, really obvious. So this is where the real difficulty starts with this root canal. We're trying to negotiate with the size 8, but it's not moving at all. And what you'll know classically is that you'll shape the 3 very obvious canals first, and then you'll spend probably just about as much time shaping and negotiating the MB2 as you did with 3 other canals. But it's really, really important that you make sure you try to negotiate down the MB2, because obviously that's where bacteria can remain and cause failure. So I'm using a size 20 and a size 25 here, just to shape the coronal third of this MB2 orifice. Of course, I don't want to go too far because I don't want to ledge, but I want to open up this MB2 canal orifice to ensure that we get as enough straight line access as possible, so the files aren't impeded when they're trying to negotiate. I'm just using a size 6 C+ file here. I'm just having a little feel around. I feel like I'm getting a little bit of negotiation. It's getting there. There is a little bit of negotiation, but these are really fragile files. You've got to be careful. But as we sort of negotiate down the MB2 with this size 6 C+ file, we push it out and we notice a very, very small bend there. So, there's a possibility that maybe the MB1 and MB2 join. So it's just a case of in and out with our ham files. And then I'm going to use a higher diameter size 8D finder to kind of do this kind of step back approach to open up this canal. And then, of course, when we pull out this size 8D finder, we notice that bend again. So again, it's kind of in the back of your mind, you're thinking to yourself, do these canals join, or are just really, really closely associated? So what I'm going to do to try and check confluence is I'm going to get a GP cone. I'm going to fit it to the working length in the MB2. And then I'm going to get a hand file here to try and check confluence by marking the GP cone. We try and mark it, we pull the GP cone out, and there's no mark on the cone at all. So, this is not to say that they don't join together, but at the moment, we haven't got that join at all. But I'm doubting myself a little bit, so I get the GP cone, I get the hand file again, try and push it down a bit further. But again, we inspect the GP cone, and it just isn't marking the GP at all. So, give it a little bit of irrigation. We just checked to the furthest point we reached is about 18 millimeters. So I'm going to try and shape with my glide path file at 17 millimeters. So this is a millimeter away from the furthest point reached in the MB2. And I'm being dead careful here because the MB2 is very, 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 very narrow. Same again with a size 20, trying to open up this MB2 canal orifice. And then once we've shaped this up, we got our D-finder in, and we hook it up to the OPEC locator, but it screams 0 straight away. And it screams 0 quite far back. And again, we think there's a little bit of a short circuit here with the irrigation. So I'm just going to remove some of the irrigation from the canal orifice, and we can see now that it doesn't scream 0, but it looks like we're very, very, very close to the end on this, but we're not quite pushing out to the end. So this could be this could be like 5 millimeters away, or it could be very, very close. And when we hook it up, we can see that we've negotiated just maybe 2 millimeters more, and it's the same kind of protocol as before. We're just going to be shaping to about 0.5 or a millimeter away from its furthest point reached, and we're going to just do that kind of step approach where we're going to be in, clean, irrigation, recapitulation, and we're just very, very, very slowly go into length. But I pull out my size 20. I'm very, very, very conscious now of file fracture. So I'm just checking the flutes on this rotary file just to see they haven't unwound. And then when we look very, very closely, we irrigate and aspirate the MB canal. And what we notice straight away is that the MB2 also drains at the same time. So this is where we're in a bit of a pickle at the moment, because what we could do is we could just expect that these two join and obturate. We could take a cone beam CT scan to see if they have got a true join, or we could try and do more shaping and risk file fracture. But as we sort of shape this up, I really, really am keen to check this confluence here. So I get a size 25 GP cone, I get a size 8, get a size 10 D finder, size 8 T finder to try and mark this. We have a little look at the end, and there's absolutely nothing at all. There's no mark. So we're kind of at a bit of a precipice here, because we could just obturate, or we could just keep going. And just off the off chance, I pick up my size 8 D finder, we negotiate. I feel like maybe this is going a bit further to length. And then, we hook up the apex locator. We've got that kind of short circuit again. So I just need to get my irrigation syringe and possibly remove some of the irrigation. Why is this short circuiting? I'm not entirely sure. I don't know if this is the apex locator or the palatal canal is quite wide, or maybe it can't be the tooth itself, because it's not got a huge restoration. And we do this final working length check, and we are very, very, very close. And what we have to, or what I've done this case, is I've just accepted that we're very, very close, and we can't get to the end. Some people might suggest taking a cone beam CT scan, although we had a very, very long conversation with the patient about this, and they were happy to just filter as far as we can get. What I don't want to do is cause this fracture file in there. So we know how far we've got. We're just going to do some final shaping with a glide path file, with a size 15 glide path file, with a size 20 rotary file. And of course, because the canal is so tight in the MB, and my final shaping file is going to be a size 20 rather than size 25. And then we're just ready for our cone fit radiograph. Of course, I'm going to place a 20 size 20 GP cone in the MB2, and then as we kind of get to the point where we're about to place the palatal, we crimp it to the proper working length, and as we push it to length, it pushes past the crimp. So we know that the palatal is not being apically gauged properly. So what we do is we pull it out, so it shows that the GP is pushing at 19.5 millimeters. So we just need to remeasure the GP cone, and in this case, it's a size 25 match GP cone. I'm going to push it through the 30 GP cutter. We're going to obviously measure it back to 19 millimeters, and then we fit this newly cut cone to length so it feels snug, and it feels like it's still pushing a little bit past this sort of reproducible point. And it's kind of that pull it out, check the length, give it a cut, push it back to length again, and in and out until you get that confirmed working length. And we get to maybe 45 in this place, and now it fits snugly. However, we take a cone fit radiograph, and then clearly the palatal is short. Now, sometimes, we've seen on x-rays that these palatals are short, and we recheck with the apex locator, and that's the correct working length. But I feel like this is a bit short than I'd like. So what I want to do is I just want to remove all the GP cones for this infection, and I just want to recheck, or I'm kind of thinking about what I should be doing in this case. Again, I'm not entirely sure if it is the working length. So what I want to do is just want to check that the cone isn't wrong. So I'll just fit it to length. I feel like maybe, the cones are, fitting the GP cone correctly. And I think the next thing for us to do is just to check the working length. That's always a good shout. And as we sort of check the working length, we can see that the working length is actually 21 millimeters, not 19.5 millimeters. So maybe I used the wrong sized hand file or whatever, or it doesn't matter. We've got the incorrect working length. We're going to just fit the GP cone to the correct. We're just going to fit the GP cone in the palatal before we do any sort of prep at all to see if that fits. The GP cone doesn't quite fit to length, so we just need to do a bit of extra shaping because we used our rotary file to 19 millimeters instead to 21. And then we take a cone fit radiograph after reshaping the canal, and we can see now that this is kind of at the correct length. The GP cone is ever so slightly concertina at the end. Slight worry, but we're going to hopefully use our bioceramics to kind of reach in that area. So we're ready to do our obturation. And it's not really an obturation video, this, so I'll just sort of skip over this and we'll go straight for the post-op. And we look at this x-ray and, it looks adequate. I would say the vast majority of dentists would be very, very happy with this. I'm happy with it. It just isn't Instagram ready, is it? We know it's the length. If we look really, really closely at MB, we confirm the working length in this case, but maybe it's short. It's hard to say, but overall, I'm really, really happy. And thanks for watching. If you have any comments, criticisms, questions, please put them in the comment section below. And I'll see you next week in the next video. Bye-bye.